Our next speaker will be Dr. Francesco Cognetti, who will be presenting results of the epirubicin and cyclophosphamide followed by paclitaxel versus fluorouracil, epirubicin, and cyclophosphamide FEC, followed by Taxol, all given every 3 weeks or 2 weeks in node-positive early breast cancer patients. Final results of the Gruppo Italiano Mamella 2 randomized phase 3 trial.
Thank you. On behalf of the Gruppo Italiano Mamella, I will present the final results of the randomized phase 3 GYM2 trial on node-positive breast cancer patients. The widespread application of adjuvant systemic therapy, hormonal, chemo, and biological treatments following primary surgery has produced a major impact on disease-free survival, both in premenopausal and in postmenopausal women with early-stage breast cancer. Chemotherapy regimens containing anthracyclines and taxanes have emerged as the international standard in high-risk node-positive cases. At this regard, no data are available on the utility of adding 5-FU to adriamycin or epirubicin cyclophosphamide combinations, and further attempts to improve the outcome with standard chemotherapy have focused on either dose-intense, higher dose, or dose-dense, more frequent administrations strategies. A systematic review and the meta-analysis of 10 randomized trials regarding the efficacy and toxicity of the dose-dense chemotherapy approach in 3,337 high-risk non-metastatic breast cancer patients demonstrated the dose-dense chemotherapy results in better overall and disease-free survival. However, additional data from randomized trials are needed before dose-dense chemotherapy can be considered as the standard of care. We have designed a factorial randomized trial by evaluating both the addition of 5-FU to epirubicin cyclophosphamide combination and the acceleration of chemotherapy. Patients in arm A received epirubicin 90 mg per meter square plus cyclophosphamide 600 mg per meter square intravenously on day 1, cycles repeated every 3 weeks for a total of 4 courses, followed by paclitaxel 175 mg per square meter intravenously on day 1 every 3 weeks for 4 courses. Patients in arm B received 5-FU 600 mg per square meter plus epirubicin and cyclophosphamide followed by paclitaxel at the same doses and schedule than arm A. Patients in arm C and D received epirubicin cyclophosphamide plus or minus 5-FU repeated every 2 weeks for a total of 4 courses, followed by paclitaxel every 2 weeks for a total of 4 courses. Pelfiglastim 6 mg starting 72 hours after each cycle of chemotherapy was administered to all patients in arm C and arm D. Primary endpoint of the study was invasive disease-free survival, and secondary endpoints were overall survival and toxicity. The study was designed to detect a minimal therapeutic effect of 20% relative reduction in relapse incidence, second tumor, or death, requiring at least 2,000 patients with an average follow-up time of 6 years. From April 2003 to July 2006, 2,091 patients were randomly assigned to the 4 treatment arms. The median follow-up was 7 years. The distributions of the main pretreatment characteristics, age, menopausal status, surgery, histological type, tumor size, and number of positive nodes. And also histological grading, HER2 status, hormone receptor status, and proliferative activity were similar in the 4 treatment arms. 88% of patients started and completed 8 cycles of chemotherapy, with no substantial differences between the 4 treatment arms. At a median follow-up of 7 years, 266 patients have died, 103 patients in the dose-dense arms and 163 patients in the standard dose arms, 143 patients in the FEC arm, and 123 patients in the EC arms. Furthermore, 521 events, local or distant relapses, second primaries, breast or others, or deaths without relapse have been registered. 224 in the dose-dense arms and 227 in the standard dose arms, 270 in the FEC groups and 251 in the EC groups. A not significant test for interaction on primary endpoint confirms the appropriate use of the factorial design. At a median follow-up of 7 years, no significant differences in invasive disease-free survival and overall survival were observed between arms containing the FEC or the EC regimens, so the addition of 5-FU to EC combination did not improve clinical outcomes. Invasive disease-free survival was significantly better in the dose-dense arms versus standard dose arms, with a 5 years disease-free survival rate of 81% versus 76%, hazard ratio 0.78, p-value of 0.002. Also, overall 5-year survival was significantly better in the dose-dense chemotherapy versus standard chemotherapy, 94% versus 89%, hazard ratio 0.68, p-value less than 0.0001. The analysis for subgroups showed that accelerated chemotherapy improved disease-free survival regardless of clinical and pathological characteristics, but patients with younger age, premenopausal status, T3, T4 lesions, more than 4 positive nodes, histological grade 3, and ER/PR negative had even a greater benefit. In particular, the benefit associated with dose-dense chemotherapy was particularly pronounced in receptor negative patients versus hormone receptor positive patients, as a ratio 0.67 versus 0.80. Patients treated with dose-dense chemotherapy experienced more frequently anemia, all grade 67% versus 49%, with standard chemotherapy with p-value of 0.0001, and bone pain due to the pelvigrastin administration, 53% versus 39%, p-value less than 0.0001. Neutropenia occurred more frequently in the standard schedule arms, 67% versus 28%, with a p-value less than 0.001. Grade 3 and 4 toxicity were generally very low. Only grade 3 and 4 neutropenia at the higher rate, the standard schedule, with a 42% versus 14% in the dose-dense arm. Other grade 3 and 4 toxicity occurred rarely, with the same incidence in the dose-dense and standard dose chemotherapy arms. In conclusion, dose-dense chemotherapy as adjuvant treatment in node-positive breast cancer patients improves significantly invasive disease-free survival and overall survival. The advantage is independent by clinical and histopathological factors. The addition of 5-FU to the pirubicin cyclophosphamide combination does not improve clinical outcomes. The use of pelfigrastim allowed a safe administration of the dose-dense regimen. The dose-dense chemotherapy regimen used in the present trial is an optimal option in the clinical practice for the adjuvant treatment of node-positive breast cancer patients. I would like to thank all the investigators, all the patients who participated to the study, and a special thank to Marco Venturini, a friend, an outstanding clinician, a clinical researcher who left all of us too early. Thank you very much.
Congratulations. Microphone 4.
Thank you for Vogel, New York. Thank you for a wonderful presentation. There were some data from a small phase 2 study at Memorial about 10 years ago suggesting that dose-dense FEC was too toxic, too much stomatitis, some pulmonary toxicity. Was it too toxic in Italy?
The toxicity is much more for anemia, for bone pain, but was very inferior to the standard treatment arm for leukopenia and neutropenia in our trial. No cardiotoxicity was observed. We observed also 2 cases of acute leukemia, one lymphatic and one myelogenic, in the accelerated treatment arm.
Microphone 1.
Vogel, not New York, Miami. Excellent presentation, solving a couple of new issues. I mean, we've been puzzling over the addition of 5-FU for 25 years, and it looks like you've put that one to rest. And the second issue is that you have confirmed the results of the CALGB trial showing that in dose-dense therapy, if you look at the hormone receptor status of the patients, that the bulk of the benefit for dose-dense therapy is in hormone receptor negative patients and not hormone receptor positives.
Thank you. I confirm that 5-FU should be deleted from anthracite combinations in treating in the adjuvant setting patients with operated for breast cancer and nodal positive.
Microphone 5.
Well, Miami again, Stefan Glück. Congratulations. One quick question about cardiotoxicity you didn't mention. Cardiac toxicity.
We did not observe any case of cardiotoxicity in the 4 treatment arms. At least evident at the clinical level.
Microphone 4.
Congratulations again, Volker Möbus from Germany. Last year, we had 2 negative reports from dose-dense trials. This was a TEC2 trial from the UK and the CALGB B38 trial. And both trials had a very low risk group of patients. The median number of positive nodes was 1 in the TEC2 trial, and it was 2 in the CALGB trial. And CALGB also recruited no HER2 positive patients. So I would be interested in your Italian trial, what was the median number of positive nodes? I suppose you had a higher median number than 2.
In our trial, 60% of patients had 1 to 3 axillary nodes positive, 25, 4 to 9 and more, and 15 more than 10 lymph nodes involved.
Thank you very much.